Okay, good morning, good afternoon, good evening po sa lahat. Saan mong panig po kayo ng mundo naroon. Welcome po to our 187th episode of our Health Updates webinar series. Something that to think about po, no? It's been almost 4 years now, or more than 4 years na pala, since we started this program. And we're very, very fortunate and very humbled po that you continue to trust us as your credible online community. And for all those who want to participate, you are more than welcome po to join us each and every Friday from 12 noon to 1 p.m. Ang pag-uusapan po natin for today, slip discs. So ito po ay medically termed as herniated or prolapse discs, and they present a multifaceted challenge sa clinical practice po, no? Mainam po na maintindihan ang ating underlying anatomy, the pathophysiology, and diagnostic modalities. These are paramount po for accurate identification and effective management. So for our webinar today, we'll have very, very distinguished experts po, no? And they will delve into the intricate nuances of slip discs. Ano po yung mga, let's say, mga myths about it. Paano po siya unang nararamdaman? Paano po siya tinitreat? Ano po yung latest advancements po patungkol sa diagnostic techniques? And then we'll discuss po ano po yung mga, treatment modalities. Maybe there are conservative measures that can be done to as extreme as surgical intervention just for us to better understand how to cater to individual patient needs. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during a regular Friday, and also looking forward po to co-hosting this program. And for today, we have po none other than one of our stalwarts po, our regulars. She is the coordinator for training at the Philippine General Hospital, Dr. Dion Sakdalan. Dr. Dion?
Hello, good afternoon, Dr. Raymond, and good afternoon to all our guests this morning, to our speakers, and of course, to everyone here in the live broadcast of Zoom's webinar, and to all those watching via live streaming on the TVUP YouTube channel, as well as on the UP System Facebook page, the TVUP Facebook page, and of course, all those watching from TVUP Signal TV channel 101. So good afternoon also to all our speakers. I mean, there's two of them here and they're friends from med school. Dr. Dave Dizon from the Department of Orthopedics of the PGH, and Dr. Jen Yang from the Department of Rehab Medicine. So again, we've seen our previous episodes, and in our opening billboard, we're now calling this series of webinars health updates. Hindi na po siya Stop COVID Deaths, and we have done a little reformatting of our program, but we are still maintaining the same high quality information dissemination and discussion, and we are now leveling up to take a closer look at existing and emerging health problems in the Philippines and the rest of the world. So as mentioned by Dr. Raymond, today we'll be talking about back pains, slip discs. And this is something close to my heart because as we everyday work, at the end of the day and even in the morning when we wake up, we get those lingering pains or minsan bothersome pains. No? So I'm really looking forward to learning from this webinar. So before I think we proceed with the presentation of our distinguished guests, Dr. Raymond will probably have to discuss or talk to us about our POTS video.
Yes,
Dr.
thank you.
Raymond?
Yes, thank you, Dr. Dion, for our person on the street video. And this is something that we play just to set our discussion into context and try to determine ano po yung baseline knowledge of our audience about it, especially the common folks on the street. The questions that we ask them are as follows. Ano po ang inyong alam tungkol sa slip disc? Ano po sa tingin ninyo ang madalas nararamdaman ng taong may slip disc? Sa tingin po ninyo, ang mga pasyente bang may slip disc ay palaging may back pain? At may kakilala ka bang naoperahan na dahil sa slip disc? Nakakatulong ba ang pagpapatingin sa mga chiropractor para maitama at pagalingin ang slip disc? Please watch this.
Ang slip disc, sa pagkakaalam ko, isa siyang sakit na kung saan ang isang pasyente ay nakakaranas ng back pain, pamamanhid, at pananakit ng legs at braso.
In my knowledge, isa siyang illness na ang lumbar disc natin ay it's either nag-slip o nag-leak, causing parts of our spine to inflame, which causes back pain or sciatic pain.
Yung inner part ng slip disc, it extends through like a tear of the outer portion of the disc, and if it's severe enough, it can compress the nerves near to it, which can cause pain.
Based on my experience, extreme back pain in the lower back, radiating through the legs and feet. Tapos, mahihirapan ka maglakad, mahihirapan ka mag-function, hindi ka makatulog. Pain usually is worse sa gabi.
Ay unang-una sakit o pain, tapos depende kung saang parte ng spine ito, kung mataas o mababa, yung maapektuhan niyang nerves, pwedeng mag-extend yung pain sa ibang parte ng katawan. Kunyari daw mababa yung slip disc, pwedeng yung pain na to mag-extend hanggang sa paa, sa thighs.
Naoperahan, wala, pero na-treatment, nadaan sa treatment. Dali, kumonsulta kami sa doktor, and then treatment siya. Yung husband ko, si Adrian Ong.
I think it depends on the severity of the slip disc. So if the slip disc is mild or not really that severe, people may be asymptomatic, so they won't experience any pain. However, if the slip disc is quite big and it impinges on the nerves near it, then patients can have chronic pain.
Sa tingin ko, well, nakakatulong siya sa iba, effective naman. Pero sa iba nga, as sinabi ko sa husband ko, iba naman yung pagpapagaling na ginawa. Yun nga yung treatment na, shock treatment na ginawa ng doktor sa kanya.
I'm not really aware of how chiropractors address slip disc, because I think a treatment that I'm most aware of would be physical therapy or surgery, as you mentioned. Being someone who has the slip disc, it gets hard to do some of ordinary activities, such as maybe sitting for long periods of time or walking for an extended distance. So normal things like that.
And basically, it is like living hell on earth. Dahil kahit anong gawin mo, kahit anong gamot na inumin mo, very painful. Actually, mas painful pa siya based on my experience, it is more painful kesa sa toothache. Actually, it is one of the most painful na nararamdaman ko. It is traumatizing.
Thank you so much, TVUP. Just trying to imagine lang po, no, people who have experienced this, and in particular, in our last interviewee po, no, I think he and his spouse, they suffer po from sleep disc. So it's kind of disconcerting, but at the same time, it's a reality, and hopefully we'll be able to shed a little bit more information po about sleep discs. How did you find it, Dr. Dion?
What struck me is the statement of living hell on earth. And it's really that level of pain that these patients are experiencing. And hopefully from this webinar, we learn more about it. Hopefully they can also give us, preventive measures. How do we not have these kinds of pain? So I'm really excited, to hear about their presentations. But before we present our first speaker, maybe some house rules, Dr. Iman.
Yes, thank you. Thank you so much, Dr. Dion. So for our webinar today, especially for those who have been asking po, no, you need to be able to watch at least 50% of the webinar duration for you to be able to receive a certificate of attendance. We have already sent out for all 186 episodes the certificates of attendance, and we have answered the other requests po, no, that we have been receiving via email for, let's say, corrections, or maybe they did not receive it, and then upon checking further, they should have received one. So we have already addressed those. But if you continue to experience those, then please free to email us at our email address po, no, at up.edu.ph. For our webinar today, we'll be having a standard panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. So without further ado, Dr. Dion will introduce po our main speaker.
Okay, thank you, Doc Raymond. So I'm very happy and proud to present to you our first speaker to talk about slip discs. He's a friend of ours, friend from medical school. He's a clinical associate professor and attending orthopedic surgeon from the Division of Spine Surgery of the Department of Orthopedics of the Philippine General Hospital. Please welcome Dr. Dave Anthony Dizon. Good afternoon, Dave.
Hi, good afternoon. So I'm here at the spine unit of the Department of Orthopedics. Hopefully, the internet here will cooperate today. I guess, should I start?
Yes, go ahead, sir.
Yes, go ahead,
Yeah.
Dave.
So today we'll be talking about lumbar disc herniations, how to sort out this problem, which people would usually refer to as the slip disc. So a brief outline will be going through what the slip disc is, common clinical presentation, how to evaluate your patient, and options for treatment. So I have no disclosures. So when we refer to the disc, we're actually referring to this joint right in between the bones of your spine. So it goes all the way from your cervical going down to your lumbar spine. Your sacrum normally does not have a disc anymore. That should have, it usually fuses around the time of childhood. But for the sake of this discussion, we'll be referring to the lumbar intervertebral disc. So in between your bones, you have this structure called the disc. Outside is a thick fibrous material called the annulus. And inside is a gelatinous structure called the nucleus pulposus. And in medical terms, when we talk about slip disc, it's more or less what we refer to in medicine as a herniated disc. So if you hear doctors speaking, we'll be talking about herniated discs. Slip disc is more of a layman's term for it, and it usually refers to a rupture of the disc, such as the nucleus leaks out and pinches on the nerve. And what does that do? So this is one common question that I get. What's the most common symptom of a lumbar disc? Does the patient come in because of back pain? Is it pain radiating down to one leg or foot? Or does the pain radiate going down to both legs? Or is it just pain at the back of your thigh? So we'll be going back to this in a while. This is a common patient that I get. Middle-aged adult, office worker coming for low back pain, usually 2 weeks, 1 month history, no recall trauma, relatively insidious onset on physical examination, tense lower back muscles, no neurologic issues. And sometimes this patient might come to the clinic and will say, "Doc, may slip disc yata ako." Or in some cases, they might have been told by their doctor that they might have a slip disc and they need an orthopedic consult. And in some cases, they even have already an MRI with findings of a slip disc and referred to ortho for further management. So how do you determine what the problem really is? And in most clinical practice guidelines, particularly this one from the APS and the American College of Physicians, and actually most guidelines that you'll see, Very important. Always start with a good history and physical examination, because it's only by doing that where you will be able to classify your patient if it's really just non-specific lower back pain, if you have back pain with radiating to one or both extremities, so what we would term as a radiculopathy, or your back pain may potentially be due to other causes, like let's say cancer. It's also important that you try to ascertain if there are any psychosocial risk factors, because, I mean, if you try to treat these patients, the outcomes are not always going to be good. And your focused history should characterize the pain of the patient. Saan ba sumasakit? Okay, is it back pain? Is the pain radiate going down to one leg or both legs? What's the frequency of the symptoms? Is it there all the time? Does it recur on a daily basis? Pero nawawala rin. Worse in the morning, worse in the afternoon. What's the duration of the pain? Is it there the entire time? Or yun, pabalik-balik lang ba? Is there a history of previous symptoms? Has it happened before? Was it treated? How did it respond to the treatment? Also, try to determine if there are any neurologic deficits, particularly if it's progressive or severe, because this can be a red flag, particularly if your motor deficits are at more than one level and if you have fecal incontinence or bladder dysfunction. And this is important because this might be Coda equina syndrome, which is an emergency. We'll go a little bit into that later. So patients without urinary retention most likely do not have Coda equina syndrome. It's quite rare. So, but if you pick this up, that's a red flag. And talking about red flags, this is very important to determine because you want to rule out, let's say, a history of trauma, history that might point to cancer, history that might point to a spinal infection. So weight loss, fever, chills, fatigue, night pains or pain while supine, which you do not expect with mechanical back pain, history of recent infection, immunosuppression, cancer. On physical examination, is there severe tenderness, especially in a patient with a history of a fall? Are the neurologic deficits bilateral? Do you have saddle anesthesia? Again, Coda equina syndrome, or is the pain out of proportion to your expected physical examination findings? Also important, of course, try to rule out the so-called yellow flags or the psychosocial aspect to it, because this plays a big role in the outcomes of your treatment. In general, these patients don't do as well. Once you have your history and physical examination, then you'll be able to make your differential diagnosis or your working diagnosis. If you say that this patient has mechanical back pain, you will be correct up to 97% of the time. Referred pain from the viscera, it's actually not that common. Only 2% of all consults of back pain in the orthopedic clinic, and non-mechanical back pain is even rarer at 1%. So ano yung non-mechanical back pain na yan? So that is what actually people worry about. Cancer, infection, inflammatory arthritis. So it's not very common. What would be more common is this 97%, your mechanical back pain, of which 3/4 is actually just due to your lumbar strain or sprain. Essentially, you strained your back doing something. Okay? So yung kinatatakutan nyo na herniated disc as a cause for back pain, it's actually not very common. It's about 1/8 of all consults. And even then, yes, disc herniations may, in the initial phases of the disease or in the phase of resolution, manifest as back pain alone, but that back pain is actually just the start of it, or maybe towards the end of it. The actual symptom is that will eventually evolve into radicular pain or pain radiating down the lower extremity. These patients may recall a history of fall, twisting, or lifting of a heavy item. More often than not, if the kind of work that a patient does involves vibrational energy along with sustained lateral flexion and rotation, this can predispose to a herniation. Presenting symptoms, these patients may manifest with the usual muscle spasm and tenderness, so back pain. There usually is a positive nerve tension sign, sensory disturbance, and motor weakness or neurologic issues can also be present. But this would be the most striking feature. Look for sciatica. So pain radiating down your lower extremity, or what we would term as a radiculopathy. So the descriptions can be varied. Can be sharp, dull, aching, burning, sometimes parang ang lamig, sabi ng ibang patients, throbbing, pins and needles, ants crawling down the leg. And for a disc herniation, this is usually exacerbated by bending forward, sitting, coughing, or straining, and oftentimes relieved by lying down or sometimes even walking. Yeah. So that's the main symptom of a disc herniation, radiculopathy. Patient may have numbness or weakness in the legs or radicular pain, or what is sometimes termed to as sciatica. If the radiation goes past the knee, this increases the likelihood of a true radiculopathy. And the sensitivity of sciatica is actually quite high, 95%, such that its absence makes a lumbar disc herniation highly unlikely. The likelihood of a lumbar disc herniation in a patient without sciatica is actually 1 in 1,000. It's not that common. And to understand what's happening, you have to look at the pathology, because you don't often get a lumbar disc herniation with just one single episode. This is usually repetitive stress on the lumbar disc. There was a study done in the 70s where they placed pressure sensors into the discs of volunteers and took the pressure at certain positions. With the person reclining, you decrease the pressure in L4, L5 by 50 to 80%. Okay? With unsupported sitting, such as sitting on a stool, that increases the load on the disc by 40%. By leaning forward, especially if you have you're carrying a weight, the pressure on the disc increases by about 100%. And if you add rotation to your forward flexion, that increases the pressure on the L4, L5 disc by 400%. And imagine if you keep doing this repetitively, that disc is actually has a lot of nerves around it. And if you tear the annulus, if you tear that capsule, it can irritate those nerves, which will lead initially to back pain. But the nucleus pulposus is avascular. So the theory is, because your body is not exposed to that nucleus, the body will react and develop an autoimmune response such that your inflammatory chemicals accumulates around that nerve root. And eventually, even if you don't have a herniation yet, it can lead to what is termed as a chemical radiculopathy. So pain to start radiating down your leg. And eventually, the stages of this herniation will occur. So this is actually a spectrum of it. You might hear it from your doctors. You might be dealing with a disc bulge initially. This will eventually develop into a protrusion. Eventually, when you have that annular tear, it will extrude. And when fragments separate from that main disc, then you have a sequestration of that disc. So from a normal disc, it becomes like this. So that nucleus will be pinching on your nerve. And this is what is termed as your disc herniation or your slip disc. And it will pinch on that nerve, and you will feel it as along that nerve as it radiates going down your leg. So classically, the radicular pain can follow a dermatomal distribution depending on which nerve it's pinching. These different.
Okay, we'll just wait for for Dr. Dave. I think he has some connection issues naman po, but he's coming back. Dr. Dave, are you back? You're on mute, sir.
Yes, saan ako nawala?
Okay. in I think in the last 10 seconds. Yeah.
The stages of the
Yeah, stages.
herniation.
Yeah.
Okay.
Thanks, Dave.
So here. So Yeah. So essentially, those stages of herniation are just a spectrum of everything. If you hear your doctors talking about it, regardless of you're talking about a protrusion, extrusion, or sequestration, those are all slip discs or disc herniation. Yeah. But the important thing is, regardless of whatever stage it might be, it's what's happening to that pinch. Okay, and it can follow a dermatomal distribution. So depending on which nerve is pinched. Although there are studies which show now that most patients may not necessarily exhibit pain in the typical dermatomal distribution, depending on which nerve is pinched. So anywhere from L3 to S1 can manifest as pain in the buttock, posterior thigh, or the posterior calf. But so for your purposes, as long as you have pain radiating down your leg, that's a radiculopathy. So this is the commonly, ito yung mas pinagkakatiwalaan natin na totoo yung sinasabi ng pasyente na baka meron siyang slip disc. If a patient comes to you saying that may kirot sa balakang na kumukuryente papunta sa binti, that is the typical presentation of your patient with a disc herniation. So if you're asked, what's the most common symptom? Then it's usually unilateral radiating pain to a leg or a foot. So once you've done your history in PE and you're leaning more towards that particular diagnosis, take a look at your patient. Look at the gait when the patient is walking. Is their foot drop, which might be an L4-5 paresis? Do you have a Trendelenburg gait, which might mean a weakness of your gluteus medius, so meaning a pinch, possible pinch at L5? Look at your alignment. Is your patient leaning more towards one side, so the so-called sciatic list? If you have a decrease in your lumbar lordosis, it might be muscle spasm. These patients would also tend to lean forward to keep the hip and knee flexed. This decreases the nerve tension and to a certain extent helps the patient to manage the pain. Palpate the back muscles. More often than not, there will be some muscle guarding at the back. Look for muscle atrophy, especially in patients who have had long-standing neural compression. If there is generalized symmetric muscle atrophy, both extremities, then you're not leaning towards a disc herniation. You'd be looking more at a systemic neurologic disorder, such as a demyelinating disease. Okay, so the North American Spine Society recommends, particularly for the diagnosis of disc herniation with radiculopathy, for your physical examination, you do your motor testing, sensory testing, your straight leg raise, and which hopefully will elicit your Lasegui sign and the cross Lasegui sign. So we'll touch up on that in a while. So the recommendation is to do a supine straight leg raise rather than your seated. So what is a straight leg raise test, or your SLR? So the SLR test is equivalent to what is termed as the Lasegui test. If you have a positive SLR, that's your so-called Lasegui sign. And the criteria is when you elevate that leg, the radicular leg pain should occur, and that should happen between 30 to around 60 degrees from the horizontal. Some doctors would do ankle dorsiflexion, but strictly speaking, that's not part of the Lasegui sign. So what does not qualify as a positive SLR? You raise the leg, pain is in the low back alone. It does not cross the knee. Okay, pain is in the posterior thigh alone. It does not cross the knee. That's not a positive SLR. If your pain occurs at an angle less than 30 degrees, this might indicate non-organicity. Essentially, baka hindi totoo. Or your patient might have a hip joint problem. If it's more than 70 degrees, your patient might just have a tight hamstring or gluteal muscles. Note that if you reach 80 to 90 degrees, pain can occur in a normal person. So just stick to below 70. Your cross SLR is doing your SLR on the unaffected leg, on the leg which does not have pain. If you do your SLR on the opposite extremity and then sumakit yung extremity na alam yung may radiation, then it's positive. So it's actually very specific. It's more specific than your SLR for a disc herniation. If you have a positive cross SLR test, then along with your SLR, that increases the chances significantly that you're dealing with a herniated disc. And then finally, do a proper neurologic examination so that you can localize which nerve root level is problematic for your patient. Okay, very important. If you rule out coda equina syndrome, saddle anesthesia, urinary dysfunction, constipation. So if that means that your sacral roots at S4, S3, S4 are already affected, and that is a surgical emergency if that happens. So there is no option for non-surgical management for coda equina syndrome. If you do that, chances are you will never recover. If you go along the non-surgical route, chances are you're never going to recover your bladder function again. So in this particular systematic review, they took a look at what's the best diagnostic evidence, best diagnostic rules. So a disc herniation with a nerve root involvement usually involves a straight leg raise along with 3 out of these 4. So dermatomal pain, sensory deficits, reflex abnormality, and motor weakness. So if you have an SLR and 3 out of these 4, then most likely you have a disc herniation. That chances of that is increased significantly if you have a cross SLR. So when do you do request for imaging? You're done with your history, you're done with your PE. Do you request for diagnostics right away? First consult, if you have neurologic issues, after 2 weeks, after 6 weeks. So normally, we would ask for imaging, CT scans, or MRIs, but the rules for radiculopathy more or less follows also that for back pain. If you don't really need it for non-specific lower back pain, and you only need to order for it if you have severe or progressive neurologic deficits, or if you have red flags. So you have history of trauma, history of cancer, history of an infection. Otherwise, if you don't have any red flags, your patient is between 18 to 50 years old, after 6 weeks, usually a plain epilateral X-ray is sufficient. And especially if it's really just back pain, herniation-induced pressure on the nerve root cannot by itself be the cause of back pain. There are actually a lot of people, up to 70% of normal asymptomatic people have disc prolapses pressuring the nerve roots, but these individuals do not complain of lower back pain. Studies done, there were a lot of studies done on asymptomatic subjects doing MRIs, and the prevalence actually is quite significant for lumbar disc herniation. Up to 30% of patients undergoing discography, myelography, CT scans, 28% of those having MRIs, even if they're not experiencing anything, can have an MRI with disc herniation. So there always has to be a clinical correlation, and that incidence increases significantly with age. The older you are, the greater the chances of you having an asymptomatic finding on your MRI. So there always has to be a clinical correlation. Based on the local guidelines set by the Philippine Academy of Rehab Medicine, they do not endorse imaging for acute, subacute, or chronic radicular pain, especially during the first 6 weeks. So when should you order for it? Only if you have no improvement after 6 weeks. And the ACP and APS likewise recommend that you only do your MRIs if you're already contemplating an invasive procedure such as surgery or an epidural steroid injection. So what happens if you don't do anything? So that's what we talk about when we're talking about the natural history. The study by Weber in 1993, where he just treated these patients with bed rest, he noted that there was a marked reduction of pain and improvement of functional ability in 70% of these patients within 4 weeks. And in Deo in 2001, 80% treated with rest and corset had a major improvement in 6 weeks, 90% in 12 weeks, 93% in 24 weeks. So there is very good, the natural history is actually very promising. Okay. Do you need to do any pharmacologic management? Looking at the ACP and APS guidelines, looking through all of this, they don't have in terms of pharmacologic management, evidence is actually not sufficient for paracetamol, muscle relaxants, antidepressants, even anti-seizure medications, steroids, benzodiazepines. But if we go to the local, they recommend initially paracetamol, then NSAIDs, tramadol, gabapentin, anticonvulsants. So these are actually very promising. Corticosteroids and analgesic antidepressants, they suggest it only because the evidence is equivocal, and you have to weigh the potential problems along with its use. So what other conservative management? Just simple advice is less effective than doing surgery in the short term, but it can be as effective as surgery looking at the long term. Stabilization exercises, better than no treatment in the short term. This is where it gets interesting. Manipulation, which involves chiropractic treatment. It's actually better than sham manipulation in patients with an intact annulus. So wala pang punit yung capsule. This is for short and intermediate term follow-up. Okay? Traction, laser and ultrasound. There's no difference in the short term and intermediate term follow-up. But if you add electrotherapy to the traction, then it can be promising. It can help to reduce the risk of sciatica in the short term, but for back pain, doesn't really increase it. Traction and use of ibuprofen, there are side effects noted. Okay, so the local guidelines again recommend bed rest, recommend to avoid bed rest and to remain physically active. Good sitting posture, therapeutic ultrasound. Again, spinal manipulation can be a suggestion if done properly. In terms of invasive, there's good evidence for epidural steroid injection and even acupuncture. Not recommended though is heat, traction, diathermy, TENS. All of these have not been shown to help. Looking at non-operative versus surgical treatment, the long-term outcomes actually have been shown to be the same, regardless of surgical or non-surgical intervention in the long term. Although surgical intervention has been shown to have a more rapid improvement for the patient in the short term. This is reflected also in the SPORT trial. Patients who had surgery and who did not have surgery both improved substantially over 2 years. But the relief of leg pain is the most striking and most consistent improvement with surgical treatment. And which patients might not improve over time? So these are usually patients who have a comorbidity, smoking, significant back pain, fear of moving, duration of symptoms, and sciatica-related muscular weakness and reduction in reflexes. So I got a question earlier, when should you do surgery? All of the following, according to the PARM, all of the following must be present for a discectomy to be considered. If the patient has radiculopathy, especially if there is dermatomal pain and numbness, and myotomal weakness consistent with the level of the herniated disc, which is confirmed by your MRI, and if it has continued over the last 4 to 6 weeks despite appropriate treatment. Of course, progressive neurologic deficits are a separate indication. So again, failure of conservative management, you've optimized everything. The pain is severely affecting your patient's activities of daily living. You have a neurologic deficit, and you're able to identify the actual pathology on your imaging studies. Then surgery can be an option for you. So we'll go into a few cases. So this is one of my patients, a 43-year-old male businessman coming for recurrent radiating pain from the right gluteal area to the right leg. Worse when sitting, relieved by lying down with a positive SLR. No neurologic abnormalities. On MRI, L5S1 has a foraminal stenosis. So for this patient, we were initially thinking of doing an epidural steroid injection. Based on the NAS guidelines, it's actually effective for short term, about 2 to 4 weeks pain relief. Although we've seen patients na it has been sustained for up to a year. And they recommend it being done in the operating room using fluoroscopy or your intraoperative X-rays, so that your needle is guided, and this improves the accuracy of your medication delivery. So that was what was done for this patient. So you can see the contrast here, so that we know that we're in the right place. And this patient actually improved significantly and hasn't really followed up yet. This is the second case, 28-year-old female, 3 months history of right lower extremity radiculopathy, positive SLR and a contra SLR, 4/5 right ankle plantar flexion, admitted for severe exacerbation of the pain. So this is her MRI. So you can see that disc protrusion at L5S1. So initially, we did a steroid injection, which helped with her significantly. Yun nga lang, 6 months later, it recurred again when she attempted to lift a bucket of water, and she decided on surgery. So we did what we call a laminotomy discectomy, which is a patient is prone on the operating room. We go in through the back and expose half of the lamina, pretty much like this. So we expose one side. Okay, so in the old days, they would expose both sides. And after we've done the discectomy, we close it up. And unfortunately, with the way it was done previously, there's a lot of muscle detachment leading to more pain post-op. So over the years, specialized retractors were developed. So this is my preferred way of doing it. This is called a Caspar microdiscectomy retractor. So this decreases the injury to the muscles, and we're able to do an even smaller incision. So this is another variation on it. So these are what we would call tube retractors, and that's how it would look like when applied. So again, you progressively dilate the muscle, place the tube in, and you do your discectomy through that tube. And when you take it out, there is much less muscle destruction, less muscle injury. So these patients sometimes we're able to do as outpatient because the pain is not as bad post-op. And what also helps is the development of intraoperative magnification. So in the old days, they do it eyeballing, but eventually we would do it with surgical loops. So that's how I would usually do it. But in PGH, since we had our microscopes available for spine surgery, we've been doing it as what we would term as a lumbar microdiscectomy, which is the gold standard done internationally. Which brings us to the last case. 60-year-old male with radiculopathy, positive SLR with paresthesia. Okay, so this patient has what we call an extraforaminal disc herniation. So this is not exactly very easy to reach from the usual approach. So we have to go in through the side. So that's a much more difficult approach. So for this particular patient, we did something different. Okay. So we play, this is what we term as a percutaneous endoscopic lumbar discectomy. We place in a scope using X-ray guidance. And through that scope, through computer screens, we're able to visualize the nerve roots and the disc herniation and take out that disc through that scope. So from something like this, we have a less than a 1 centimeter wound now. And it's a very promising procedure. It's not inferior to the classic way of doing things. Return to work is actually much faster and the complications are much less. So, points to take home. A focused history detailing the pain description and pattern is vital to the diagnostic process. Always rule out your red flags. Radicular symptoms of the lower extremities are the hallmark of a radiculopathy from a possible disc herniation. The absence of sciatica makes the diagnosis of a symptomatic disc herniation highly unlikely. So a positive SLR, along with 3 of these 4, dermatomal pain, sensory changes, motor deficits, and DTR abnormalities can conclusively diagnose a radiculopathy. And unless red flags are present, you don't really need to do any imaging during the first 4 to 6 weeks. Most patients will improve regardless of treatment within 4 to 6 weeks. And surgery may be indicated if no significant improvement after 6 weeks of non-operative management with significant impact of the pain on the quality of life. But always, clinical findings and your imaging must correlate. And the expected outcome of the surgery is control of that radiating leg pain. It's very important to get to rule out Coda equina syndrome because this is a surgical emergency. You do not even consider non-surgical management for it. And with that, I'd like to just plug our Class 99 has a webinar series going on throughout the year. So you can search for it in Facebook using UP Med webinars and also in the page of the University of the Philippines Medical Alumni Society. So on Monday, we'll be having one on fatty liver. So that's it. Thank you.
All right, thank you so much, Dr. Dave. Very important po, no, especially dun sa dun sa mga what was striking to me was hindi dapat pala nagre-rest. Mas dapat pala gumagalaw para mas siya, gumaling ng mas maayos. Okay. Before I introduce po our reactor for this webinar po, no, we encourage everyone to put in your questions already sa Q&A session po natin. Very, very important as we are scouring din po doon sa ating YouTube and our Facebook pages. And the comment section po noon, we hope to be able to choose one of those questions to be asked dito po sa ating webinar for today. Okay. Our reactor for today po, Balik Scientist, just like yours truly po, Balik Scientist Awardee for 2023. And also attending physician naman po, this time from the Philippine General Hospital's Department of Rehabilitation Medicine. Please welcome Dr. Jennifer Yang. Dr. Jenny.
Hello po.
Yes,
Good
we can hear you.
afternoon.
Mm.
Good morning, good evening, wherever you are. I've been tasked to react on Dr. Deason's orthopedic talk from the rehab standpoint. So I'm going to go share my screen, and it's going to be shorter than his talk. Let me just
All right.
share slideshow. Can you see my
Yes.
title slide? Yes.
Yes,
Okay, good. So I call this talk Physiatry Pain Potpourri. So physiatry, another name for rehabilitation medicine. And there's really no structure to my reaction. It's just random thoughts that came up while thinking about low back pain. So we'll start with number one. Pain as a barrier to function. So function is something we deal with as rehabilitation medicine physicians and with our rehabilitation medicine team, such as the physical therapist, occupational therapists, speech therapists, psychologists, social workers, and nurses. No? So function is how you do your day-to-day things. You're dressing, you're eating, going to the bathroom, going to work, going to school, walking around. So sometimes pain will prevent you from doing all of this. So that's why we have pain as a barrier to function. And one of the things we want to do as a rehab team is to remove that barrier so you can actually have a better quality of life. So one of the things that we want to do is get the pain controlled. So you can do physical therapy or whatever else exercises that you need to do to help yourself in the long term to get rid of the back pain. So with the pain control, there are methods that are pharmacologic, which are drugs, or non-pharmacologic, not drugs, like physical therapy or other physical modalities. So sometimes when we see a person who has a lot of pain, especially post-operatively, once you get adequate pain control, you're going to see a change in personality. They're not as depressed. They're not tired anymore. They're more active. It seems like a different person by the time you discharge the patient from the hospital after surgery, if you have the pain controlled. And essential to getting pain controlled, and not just post-operatively, this is for everyone, getting enough sleep and decreasing the stressors in your life. So this is playing into the mind-body connection. If you're not stressed, if you're not depressed, if you don't have any mental or physical distress, then your pain will not be as magnified. So sometimes we have to screen our patients that, oh, okay, we have a person with pain, but we have to look at their mood also, because if you're depressed, this will magnify the amount of pain. And sometimes on follow-up, the patient will say, oh, the pain is the same. So sometimes we use a scale, 0 to 10. 0, no pain. 10, worst pain in your life, you need to go to the emergency room. So the doctor or the patient will say, my pain is about a 6. Okay, then I send you to physical therapy, give you medications, see you in follow-up 4 to 6 weeks later. And the patient says, well, it's still about a 6, but I can walk longer distances now. I can sleep through the night. So sometimes what you label the pain is not going to be what your gauge, but actually how the patient's quality of life has improved would be a better gauge for that. We talked about orthosis or bracing. The word Dr. Dizon used was using a corset. So technically, these things are called lumbosacral orthosis or thoracolumbo-sacral orthosis. These braces are named by the segments of the spine that they cross. So a lumbosacral orthosis will support the lumbar and the sacral parts of your spine in this case now. So they may help the pain by giving support, and in turn will improve function and quality of life, but often they're not definitive management. For example, if you have what we talked about, the herniated disc, these may help the symptoms, but if the disc is still there and you still have pain, then maybe we need to go to surgical management at that point. But some people do well with just the bracing. So it's really part of an individualized program. We also talked about heat. So one of our common questions is, if I have back pain, do I do warm or cold compress? So the PARM guidelines actually say heat is not recommended. Basically, that's more of a recommendation, but do people follow it? As rehab doctors, sometimes we just throw everything at the patient because we know anecdotally they've worked before. In general, if you have a muscle spasm, your muscles will relax and be less painful if you put heat on it. If it's an acute injury, like it happened within the last 2-3 days, then cold compress is probably more, cold compress or ice is probably more appropriate because we want to reduce the inflammation. But in general, if you have pain beyond the 3-day mark, some people do respond to heat. This would be a compress or a hot shower. You just don't want to expose your skin to more than 15-20 minutes of hot or cold temperatures because that will cause thermal damage. So what I generally say is 15 to 20 minutes every 2 to 3 hours as needed. This also plays into the gate control theory of pain. So what is this theory of pain? So when you have a practical example here is pag nauntog ka, if you hit your head on something, your initial reaction is to touch that area and rub it. So the mere act of touching that area and rubbing it will tell your brain that, hey, there's something else in this part of the skin that's not painful, which overrides the pain that you're feeling. So the heat, the ice, electrical impulses from tense units, even just touching it with like massage, overrides those pain signals. Again, if you look at the clinical practice guidelines, these were not recommended. However, usually these clinical practice guidelines look at clinical trials that may or may not give enough evidence for the use of these modalities. But in our day-to-day anecdotal work, these actually work for our patients. So it's really hard to say whether recommendations are applicable or not, but they're there. And finally, for this slide, topical treatment. So topical treatments are things you put on yourself, like gels or ointments or oils. You have the over-the-counter herbals like menthol or camphor, and the more regulated non-steroidal anti-inflammatory drugs, or even paracetamol. No, paracetamol doesn't come in an ointment, no. But the non-steroidal anti-inflammatory drugs may help in people who have what we call mechanical back pain, with with a reduced risk of side effects because they're not systemic. They're not a pill that you take and then that drug will go to your kidneys, your liver, your stomach, and all that. So this one is a little more local. So pinapahid mo dun sa skin of the affected area. And in some people, they do help. This is why we do core strengthening as part of physical therapy for low back pain. So core strengthening refers to the muscles that act on your trunk. And this the left side, sorry, the right side of the slide shows the can, which is an analogy, So if you have a soda can, you have to have strong sides for it to stand up. If you crush one side, everything else will collapse. So the same thing happens with your trunk here. So sometimes we're going to think, okay, it's back pain. We have to focus on strengthening the back. No, we also have to focus on strengthening the abdominal muscles. We have to focus on strengthening the diaphragm and the pelvic floor through breathing exercises because you need all these components to have a strong core. And what exactly is the core? So these are the muscles that we usually think of, the abdominals, the lower back muscles, the gluteus muscles or on your buttocks. But the core also encompasses the anything from the shoulder to the knees, basically, because those muscles that connect the shoulder to the trunk and the lower extremities to the trunk have attachments to those other joints. And this is where we think about the kinetic chain. So the shoulder will affect the abs, the abs will affect the gluteal muscles in the lower back. So we have to strengthen all of these. And this picture of a person doing a push-up just illustrates how all of them are connected in strengthening your core. Finally, there's this one syndrome called piriformis syndrome, which you also have buttock pain and you also have pain going down your leg, but it's not coming from your back. The pain generator is actually this muscle in your buttock called the piriformis. Doon naiipit yung nerve. That's where the nerve gets compressed instead of where it comes out in the back. One way to differentiate this with herniated discs or discogenic back pain is you put the patient in a position that will compress the nerve. So prolonged sitting, going uphill or sending stairs will make this pain worse. And with that, thank you. This is a picture of the PGH and we're ready for the open forum. Thank you.
Okay, thank you so much, Dr. Jenny Yang. Okay, so well, maybe we'll start the ball rolling na just in the interest of time, Dr. Dion. If you have any questions, please feel free. I have maybe one or two here, but please go ahead.
Well, I think Dr. Davison answered the question in the Q&A about implanting titanium, and Dr. Dizon already answered that, but it's for another indication and not really for slip discs. Siguro yung question ko to both would be, we talk about slip discs and how we diagnose it, how we manage it, whether it's non-surgical or conservative. But for everyone here, being afraid of that, living hell on earth feeling, how do we prevent it? I think that's very important. How is it preventable and how do we do that?
Well, I think if you were paying attention to my slide on disc pressures, so you want it's never one single episode. I mean, it can happen na I always get a history of patients na biglang sumakit, may binuhat sila na balde. That's a very common history. So it's all about taking care of your back, good posture. You try to avoid, when you do your lifting, you want to squat down. You don't want to bend down because that can significantly increase the pressures on your disc. Kasi at the end of the day, it will all add up eh. You might say, oh sige, I'll do this today, tomorrow, the rest of the week, hindi iba na yung gagawin kong diskarte. But at the end of the day, it's all going to add up. And at some point, if you keep doing it, eventually it's going to rupture. My favorite analogy dyan is kumuha ka ng yero eh. Kumuha ka ng yero. Every day, you try bending it. Sa simula, it's just going to keep bending. No problem. But if you do that every day for several weeks, at some point, you'll see a crack developing dun sa yero. And eventually, you'll actually be able to break it.
Yeah.
Right. So it's posture and being very conscious about your movements, proper bending or picking up
Yes.
stuff on the ground. Thank you, Dr. Dizon. Dr. Yang?
Yeah, I'm going to add to that. So we go back to the core strengthening. So we're going to strengthen your back. We have to strengthen your abs also. And by doing that, you're going to put a lot more pressure. Your body's load, your body's weight will be more on the muscles instead of the spine and the disc. So that's another way to strengthen, to prevent this. No, once I had a patient who was had a slip disc from doing burpees, from exercise, needed surgery because of that. No, so if you're exercising, proper technique will also help, and warm up before doing your major exercise, the major portion of your exercise.
Pero Dr. Yang, for that
Thank you.
patient, meron na talaga siyang slip disc na lumala lang, no? Hindi naman siya nagka-slip disc dahil sa burpee.
We're not sure. We're not sure. This was a young patient. This was like 25, 26, and usually very fit. But I think kulang yung warm up niya, or the technique was off. So I think that's what happened.
Yeah, that's very important eh, yung technique eh. A lot of kids nowadays just look up these exercises on YouTube and susundan nila yung nandun sa YouTube eh. But if they may not be adopting the posture properly, as unlike if, let's say, an actual coach who knows how to do these things or supervising. So yun, if you're not adopting the posture properly, or iba yung ginagawa mo dun sa actual na ginagawa dun sa YouTube, you're trying to do it as you see it, then yun, you might develop an injury.
Thank you. Thank you for the very practical recommendations. Dr. Raymond, do you have questions?
Yes, I think that this will be our last question po. But I think they need a reiteration po. Yung po bang mga hilot, sila rin po ba ay chiropractor? At kung yung mga hilot po na marunong may chiropractor na po ba ang tawag sa kanila? At pwede daw ba silang magpatingin doon? Dr. Dave.
Well, Jenny probably has more exposure to chiropractors from her practice in the States. Ang problem dito kasi sa Pilipinas is chiropractors are not registered with the PRC. They're not covered by the Professional Regulatory Committee. So we don't know, we don't have any quality control for them. We don't know if they got the proper training and all that, because in abroad they have to do ilan years yun, Jenny? 4-year course?
4-year course, yeah.
Okay.
Doctor of Chiropractic, at least for the US.
Yeah, so therefore a hilot is technically not a chiropractor, but at least not in the educated sense.
Yeah.
Dr. Yang, go ahead.
Yeah. I think they're two different things eh. Kasi yung hilot is traditional medicine in the Philippines na yun nga, hindi siya regulated. It's traditional, passed on from person to person through the generations. So it's more of an apprenticeship and not regulated. Chiropractors, at least US-wise, they have to go to school, get licensed and all that. One of my favorite stories here is one of my preceptors, one of my teachers nung residency, was a chiropractor before he became a doctor, because he felt that as a chiropractor, he didn't have enough to offer his patients. So that's why he went to med school after. So iba din, iba ang training nila, and I think from the medical literature, yes, manipulation will help in the short term, but long term it might be not as helpful.
Okay. Okay, I think that should be our last question po, no, for our webinar. Again, thank you so much to our consultants from the Philippine General Hospital. At this point, we'll be launching our panel evaluation poll. It's 5 questions, 4-point Likert scale, encouraging everyone to put in their answers po dito po sa ating panel discussion poll. You should be seeing it in your screen popping up. I'll read these and then we'll go ahead in our closing. So number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, panelists used appropriate language or technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. Again, we would like to thank Dr. Dizon and Dr. Yang for their expertise and taking the time out to share the insights on this topic po on sleep disc. For next week, what do we have, Dr. Dion? I think she got frozen because her
Doc
videos.
Raymond, I don't
Yan, okay.
know. Maybe you have to tell us what's up for the next week.
Yes po. So for next week po, no, we'll have our very own chancellor,
I
hopefully.
think we're talking about this or
Opo. So for next week, we'll be talking about rheumatism. Not sure of the specific po na topic that we'll be covering, but we'll be very, very honored and privileged po to have our own chancellor, Dr. Michael T, to be the one to talk about this very important topic. So as you mentioned po, no, so as we are moving along, especially here in the in the hot days of summer, so to speak. So we tackled one for sports, this one for sleep disc, and then another one naman po for rheumatism, and then hopefully we'll be able to tackle something that's a little bit more in the news po, no, that we have been trying to schedule, which is yung outbreak on pertussis, and hopefully that's something that we could tackle in the next 1 or 2 webinars from now po. Before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel po, no? So you just open your app po, YouTube app, or if you prefer sa browser, www.youtube.com/TVUPPH, you'll be able to see all of our webinars here, 186, and then after today, it will be 187 po. And then including our shorts. Meron po tayong shorts video. This po na part, okay? If you go to the same webinar, YouTube page po, no? youtube.com/TVUPPH, you'll be able to see our 1 to 2 minute short videos po, no? That we really week in, week out work very, very hard to put in. Okay. So that that essentially concludes po our webinar for the week. Again, thank you so much to the Department of Orthopedics and Department of Rehab Medicine for taking the time out to give your inputs po and your insights for this important webinar for discussion. And we hope to be able to see everyone again next Friday from 12 noon to 1 p.m. It's a date. Oh, okay. So nawala na si Dr. Diana. So thank you again, and keep safe, everyone. Keep healthy, and see you online.